All right, future doctors, welcome to this Clinical Explainer. Today, we're taking a really close look at a highly significant, broad-spectrum class of synthetic antibacterial agents, the fluoroquinolones. Now, as graduating medical students, you already know that prescribing antibiotics isn't just about, matching a drug to a bug. It's about deeply understanding the pharmacology behind your choice. Fluoroquinolones are absolutely incredibly powerful tools in our medical arsenal, but they're also a massive clinical double-edged sword. They demand precision, they demand respect. So let's explore exactly why that is.
Okay, let's dive right into this. Have you ever wondered how exactly the addition of just one single fluorine atom to the older quinolone structure created such a relentless, synthetic bacterial assassin? It's fascinating. That one simple chemical modification completely transformed the drug's penetration and potency, and it really set the stage for decades of clinical success. It basically turned a very limited-use compound into the systemic powerhouse that's capable of hunting down pathogens across multiple organ systems.
Here's our roadmap for today. We're going to quickly cover their mechanism of action, the evolution of the drug generations, pharmacokinetics, clinical indications, their severe safety profile, and finally, bacterial resistance mechanisms.
Part 1. Mechanism of action and targets.
Understanding how a drug operates at the molecular level is absolutely the foundation of rational prescribing. By definition, fluoroquinolones are synthetic, bactericidal antibacterial agents. Actually, let me really emphasize that word for a second, bactericidal. Unlike bacteriostatic agents that just kind of pause bacterial growth and wait around for the immune system to do the heavy lifting, fluoroquinolones actively and outright kill the bacteria. And they do this by directly interfering with the very blueprint of the cell, the DNA synthesis and replication process.
Think of bacterial DNA replication as this incredibly complex factory machinery. Fluoroquinolones basically go in and sabotage two essential pieces of that equipment. In gram-negative bacteria, their primary target is DNA gyrase, which is also known as topoisomerase 4. Normally, this enzyme acts to relieve the severe supercoiling of DNA. Without it, the DNA just gets hopelessly tangled up. Now, over in gram-positive bacteria, the target is topoisomerase 4, which is responsible for separating the newly replicated daughter DNA strands during cell division. So by blocking these specific enzymes, DNA synthesis just comes to a grinding halt, and the bacterial cell dies.
Moving on to Section 2, Evolution of Generations.
Let's see how this builds across the different iterations of the drug. Generation 1, like nalidixic acid, wasn't even fluorinated yet. It had a really narrow gram-negative spectrum and pretty poor tissue penetration. It was useful mainly for just simple UTIs. But then, look at Generation 2, ciprofloxacin. This brings massive gram-negative power, particularly against the notoriously difficult Pseudomonas aeruginosa. Generation 3, featuring levofloxacin, is actually dubbed a respiratory quinolone because it significantly boosts gram-positive coverage, targeting pneumococci and atypical bugs like mycoplasma and chlamydia. And finally, Generation 4, like moxifloxacin, maintains that respiratory strength but adds a crucial new weapon, really high activity against anaerobic bacteria.
Section 3. Drug movement in the body, or pharmacokinetics.
As graduating practitioners, knowing how a drug gets in, where it hides out, and how it gets out is just as vital as knowing what it actually kills. Chronologically, this journey is incredibly efficient. First, oral absorption is near perfect. We're talking approximately 99% bioavailability. That means an oral pill is essentially as potent as an IV dose, which is amazing. Second, their tissue distribution is excellent. They accumulate in much higher concentrations in the tissues than in the blood serum, heavily penetrating places like the prostate gland, lung macrophages, bones, and the urinary tract. And finally, they're excreted from the system.
But wait, here is a crucial clinical pearl that you absolutely must commit to memory regarding that amazing absorption. In the gastrointestinal tract, fluoroquinolones will actively bind with heavy metal ions, specifically calcium, magnesium, aluminum, and iron, forming these unabsorbable chelate complexes. So if your patient takes this antibiotic with a glass of milk, or an over-the-counter antacid, or an iron supplement, boom, the drug is completely neutralized before it even enters the bloodstream.
And this brilliantly illustrates a really vital difference in excretion pathways. Most fluoroquinolones, like ciprofloxacin and levofloxacin, are cleared through the kidneys via glomerular filtration and tubular secretion, meaning if a patient has renal impairment, you have got to adjust the dose. However, moxifloxacin is the clinical exception here. It exits primarily via the liver and into the bile. Therefore, even in patients with kidney failure, moxifloxacin requires zero renal dose adjustments. Super important distinction there.
Okay, Section 4, Areas of Clinical Application.
The pharmacology we literally just discussed dictates the battlefield for these first and second-line defenders. Because ciprofloxacin and levofloxacin penetrate the prostate and urinary tract so incredibly well, they're absolute heroes in treating complicated UTIs, pyelonephritis, and bacterial prostatitis. For the respiratory system, the third and fourth generations really shine in community-acquired pneumonia and acute exacerbations of chronic bronchitis. Gastrointestinally, they conquer severe typhoid, shigellosis, and cholera. Over in orthopedics, ciprofloxacin is perfect for long-term therapy of Pseudomonas-driven osteomyelitis. They even serve as crucial spare parts in special, high-stakes scenarios. We're talking ciprofloxacin for anthrax and levofloxacin or moxifloxacin as absolutely vital components in multi-drug-resistant tuberculosis regimens.
Which brings us to Section 5, the black box safety profile.
But of course, this immense power comes with a severe cost. It's time for the plot twist. Fluoroquinolones carry a black box warning, which, as you know, is the highest level of caution issued by medical authorities. When you write a prescription for these agents, you bear a heavy clinical responsibility. These are not benign drugs for a simple head cold. They carry the risk of severe and sometimes permanent adverse effects.
Let's detail this severe fallout. First up is chondrotoxicity. We're talking tendinitis and actual tendon rupture, particularly the Achilles tendon, and that risk literally skyrockets in the elderly and in folks on corticosteroids. Because it harms developing cartilage, these drugs are strictly contraindicated in children and pregnant women, no exceptions. Cardiologically, they can prolong the QT interval on an ECG, risking fatal torsades de pointes arrhythmias. Neurotoxicity is also a major concern. By blocking GABA receptors, they can trigger seizures, especially if they're mixed with NSAIDs. They also cause completely unpredictable blood sugar swings in diabetics, they make the skin highly sensitive to severe sunburns, and they carry a real risk of C. diff colitis. You have to weigh these risks against the benefits for every single patient.
Section 6, Resistance, the bacterial counterattack.
So the crucial point here is, bacteria are not just taking this lying down. Driven by widespread clinical use, they deploy three main defensive maneuvers. First, they mutate their target enzymes. Changes in the gyrase or PARC genes literally alter the shape of DNA gyrase or topoisomerase 4, meaning the drugs simply can't bind anymore. Second, they upregulate efflux pumps. Think of these as cellular bouncers that just grab the antibiotic and physically throw it right back out of the bacterial cell. Finally, gram-negative bacteria can simply lose their outer membrane porin channels, effectively shutting the front gates and making it incredibly difficult for the drug to even enter the cell in the first place.
The mechanisms, the clinical power, and the severe risks of fluoroquinolones demand your utmost clinical respect. As you step onto the wards, consider this. Given the heavy metal chelation and the dangerous QT prolongation we just discussed, are you fully prepared to manage a patient whose fluoroquinolone therapy suddenly collides with their daily antacids and antiarrhythmic medications? Keep digging into those pharmacological complexities, future doctors. Thanks for checking out this explainer, and I'll see you next time.